Okay, let's start the plenary session 5, real practice concerns of CTO PCI. I'm Yangsoo Jang, and my co-chair is Dr. Satoru Otsuji and Chiung-Jen Wu. I believe he'll be here soon. So let's start the first lecture. Kefei Dou, Why Hospital China, how to establish successful CTO program in a large PCI center.
Okay, thank you. It's a pleasure to be here to share our experience. And I come from Fuai Hospital, which is one of the largest PCI centers in the world. Even in the COVID pandemic, our case number exceeded 20,000 last year. However, there are many challenges in large PCI center. We have too many patients and large portions of transferred patients with complicated clinical and anatomic situation. And most serious thing is we have limited cath lab, one operator less than 1 day per week, and one day they have at least 20 patients. Also, we have many experienced hungry cardiac surgeons. They are waiting for still our patient. And some of the patients in our country refuse to accept the cabbage, and some of them are rejected by cardiac surgeons. So we have duty and to help them. And what we want to do is to make the whole procedure clinical beneficial, successful, efficient, and safe. But how? We need to do a lot of work on several aspects. And first of all, I think CTO is not a simple thing for a single operator, for a lonely operator. We need to build CTO teams. First, in our team, we need a senior expert. She should play an exemplary role, including technical training and morals. And moreover, we need a junior independent operators, and they did their work under the guidance of senior experts. We also need young doctors who is really potential, and they are very interested in CTO and the fears of radiation exposure. Of course, nurses and technicians are also very important. And secondly, we must train all the CTO operators, train the basic technique and strategy repeatedly. And they must know what is the CTO indication, contraindication, when to stop CTO procedure, and many technical details, including Antegrade and Retrograde, also appropriate strategy. I do believe I always suggest all of the CTO operators in our hospital to follow some very good flowchart to do CTO case. But unfortunately, 5 years ago, only 10% of our operators will follow the procedure. You can see this is a failed case several times. When we do the bilateral injection, found it a very short CTO case. And after do the bilateral injection, and we fixed this patient in 30 minutes, use Stingray. And this is another patient, the operator didn't use the contralateral injection, and then to make it sure his wire is in the true lumen, and then he dilated the lesion, and perforation happened, and we have to transfer this patient to cardiac surgeon. And some other very simple mistakes. Some doctors use very weak guiding catheter to do CTO cases. And although I presented them use IVRs can improve the CTO success rate, but most of them don't use the CTO case. We can see that if you use IVRs in CTO case, the success rate is more than 80%, around 85%. But if you don't, it's only 70%. And the third thing, I think we need to do CTO case in appropriate time. We need a preset CTO time, a whole day or at least a part of the day. No need to consider other cases. I suggest it's in daytime, but not in midnight. And this is a nightmare in midnight. I did this case, and it seems like a very simple case, but very late, around 12 p.m. And I use 8:20 to to puncture proximal cap, and I use the stingray, but it's not in the right place. But because I'm very tired and very late, and puncture the use stingray wire, but perforation happened and pressure down, and I have to do the pericardial drainage and transfer the patient to the cardiac surgery. And another thing, I think it's a teamwork. I prefer the double independent operator system. You can see the picture. These two guys are independent operator. I always let them to wear headset. And during the procedure, they guide a younger doctor to do the procedure, and they talk about every detail of the CTO procedure. And under this type of work, and the young doctor improve very fast. And I think very timely case review and discussion is also very important for the whole team. And you know, maybe you know, in China we always use a WeChat group. we set up a lot of WeChat group, and I open the discussion almost 20 hours a day. And when they meet some problems and some complications, they provide the question on the website, on the WeChat group. We discuss it, and it helped the young doctor, even experienced doctor, and improve rapidly. And sixth, I think communication with doctors from other country and other province is very important. You can see many doctors to help us, and I also go to other hospital to communication. You can see Dr. Wu is here. I will pay for it, pay you for this picture later. And then I think we need every CT operator need support from cardiac surgeon, and just now I mentioned this case. If you want to always have confidence and don't let patient die on the table, the cardiac surgeon will help you. When you have some problem, you ring the bell, they show up. That's the best thing. And I will show you this that case. The cardiac surgeon opened the chest. You can see the wire and the balloon point at the air, but they fixed this patient. And last thing I must mention is recently more and more cheap patient occurred in our hospital. And last year data showed that almost 50 patient has left main CT or moderate to severe calcified lesion in for a hospital. So I think for CTO operator, they can not only master CTO skills, but also rota, IVL, and laser, and mechanical support. Almost every technique is necessary. And actually, this is a case conducted by we trained the younger generation doctor, only 30 or 36 years old, and he did this case independently. And this is a 55 years male, EF3. EF is the 32%, RAD 66 millimeter, and we can see triple vessel occluded, RAD occluded, circumcirculated, and RC occluded. And he used the airway percutaneous airway assisted device. Actually, this is a new device, not Impala, manufactured by a China domestic factory. It's in clinical trial. And he fixed these three occluded as a vessel, and in 1.5 hour. And 1 month later, EF ejection fraction is 42%. So I do believe if we can organize a successful CTO program, it can improve the ability and the level of the CTO operator very fast and successfully. I will show you some data, and this is a CTO PCI average success rate in for a hospital, and we can see the averagely the success rate is not increased very well. It's around 75% for 3 years and no progress. But in a well-trained CTO team, we can see, of course, this is my team, our success rate increased rapidly in the last 4 years. And even many young doctors joined my team, and now the success rate this year is around 89.6%. We already did 471 cases, CTO cases this year. So I hope our experience can help more CTO teams and help more patients. Thank you for attention.
Thank you very much for your nice success result. Dr. Wu, please.
Okay. So we have a discussion after this, right?
Yes.
Okay, thank you. So the second talk will be delivered by Dr. Hasegawa from Japan. He's going to deliver a talk, Enhancing CTO PCI Planning with Coronary CT Angiography. Dr. Hasegawa, thank you. Please.
Thank you, Chairperson. I'm honored to have this opportunity to speak here today. My topic is about CTO PCI using coronary CT angiography. First of all, I think the quality of CTO PCI depends on interpretation of angio and IVUS image. When I look back after failed CTO cases, I always find something I had overlooked in angio and IVUS image. Therefore, coronary CTA plays a complementary role in interpreting these images. CTO procedure is basically composed of these 3 steps: penetration of CTO entry, and wire manipulation in the CTO body, and penetration to the distal target around the CTO exit. Sometimes, IVUS-guided wire manipulation or retrograde approach is needed. Appropriate view angle and direction is needed for the safe and reliable penetration. Information about vessel size, vessel axis angulation, and distribution of calcium is useful for effective wire manipulation in the CTO body. To obtain this information in advance, coronary CT angiogram is quite useful. Today, I'd like to introduce 2 methods that I use in my routine through clinical cases. One method is virtual IVUS, and the other is rotational slab MIP image. This slide shows the CTO case of proximal LAD. As you can see, rich collateral flow was observed from right coronary artery. Based on the angiogram alone, we cannot clearly identify the morphology of CTO entry and CTO body. Virtual IVUS image is shown here. Left side image is slab MIP image of areocaudal view, and the right side image is short axis image of CTO site. This image enables us to imagine the morphology of occlusion. Although the resolution is low compared to actual IVUS image, we can get rough information about the occlusion without wire insertion. Sorry. For example, entry site is around here. This vessel is a high lateral branch, and the calcium is located at the opposite side of the high lateral branch. And the calcium is not occupying the center, but located at the outer edge of the vessel, like this. The vessel diameter of the occlusion is about 4 millimeters, and there is no significant calcium except for this spot calc. Rotational slab MIP image is shown here. In this case, the occluded part is almost straight, and the slab MIP image is rotated by 10 degrees around the straight line connecting CTO entry and CTO exit. The vector of vessel axis around the occlusion is LAO 70 caudal 9 degrees. which means that optimal view angle for the wire manipulation is areocranial, areo to areocaudal. Based on this method, we can understand how regions are observed from each view angle. For example, the separation of branches around the CTO entry is clearly observed from areo deep caudal view, like this. Guide wire penetration towards CTO entry should be performed from areo deep caudal view. On the other hand, the CTO exit is just proximal to the bifurcation of LAD main vessel and septal branch. Therefore, the target true lumen is located lower part of the vessel from areocranial view. This slide shows CTO entry penetration. As mentioned at the beginning, the most reliable tools during CTO procedure are angio and IVUS. In this case, two guide wires were inserted into a hilateral branch. One was for IVUS and the other was for dual lumen catheter Sasuke. First, Neo 3 guide wire was used to penetrate the proximal part, but it didn't work. Next, Miracle 6 gram was used, and as you can see in the right side IVUS image, Miracle 6 gram went into the occlusion. To identify the position of guide wires, rotational angio was performed from areocaudal to areocranial view. From areocranial view, the location of entry calcium was coincident with the CT image, which means wire position is appropriate from this view angle. After microcatheter insertion, contralateral injection was performed and the distal target was clearly visualized like this. These two view angles are perpendicular to each other, and then successful wire insertion into distal target was realized. After wire passage, actual IVUS was performed. This slide shows a comparison of virtual IVUS and actual IVUS. As you can see, the resolution is much better in actual IVUS image compared to CT image. However, vessel morphology such as vessel diameter, the position of calcium, or other structures are roughly understood from CT. We sometimes treat patients with both coronary artery disease and chronic kidney disease. Next case is mid-RCA CTO, and the patient had chronic renal failure. CT angiography without contrast media was performed before PCI procedure. As shown in this slide, right coronary artery runs inside fatty tissue, so vessel can be recognized without contrast media. Information about vessel size, vessel axis, angulation, and distribution of calcium is clearly identified like this. This case is the last case and proximal LAD CTO, and the patient had chronic renal failure. The entry of occlusion cannot be identified from coronary angiogram. CT angiography before procedure was performed without using contrast media. As shown in this slide, in the proximal part, the left coronary artery runs inside fatty tissue. That's why virtual IVUS is available without contrast media. We can predict how vessels will look like from a certain direction. For example, from areocaudal view, you can see LAD, septal branch, and diagonal branch in order from the top. And calcium can be observed in the center of the occluded LAD, like this. We can also predict the vessel course. For example, from areocaudal view, LAD runs above septal and diagonal branches. And from areocranial view, LED main vessel and diagonal branch are overlapping each other like this. This is the last one. Angio and IVUS image play a leading role in CTO PCI. Coronary CT plays an important supporting role. Thank you for your kind attention.
Thank you. So our third talk will be delivered by Nasu regarding the novel Antegrade wiring for CTO PCI concept of OPV, PPV, and its clinical application. Dr. Nasu, please.
Thank you very much, Dr. Wu. Could you open your mic? Okay. So everybody knows the guide wiring in the CTO intervention is very difficult because the three-dimensional wire manipulation is needed to achieve wire crossing in the CTO region. So when we advance the guide wire while changing the chip direction, the guide wire track curve becomes a complicated three-dimensional curve with torsion, which makes guide wire behavior unpredictable and uncontrollable. So there is a need for the novel wire manipulation method to overcome this difficulty. So penetration plane method is very simple. The principle of the penetration plane method is shown in this video. So this technique we can use the re-entry, mainly the distal landing zone of the CTO. So, so where the guide wire is manipulated on a single plane, the deflection occurred when the guide wire is advanced in the CTO without rotation. So unless the direction of the chip curve is deviated by torque, the wire orbit is always on the same plane. So we call that this plane is a penetration plane. So when approaching the vessel around in the distal landing zone, the penetration plane is a plane in which the vessel appeared straight. So the penetration plane view is from the direction that makes the plane appear flat, so the guide wire will always appear straight. The view perpendicular to this plane is called the objective perpendicular view, OPV, and manipulating the wire in these two planes is the basis of the penetration plane method. So there is a summary of the terminology. So PPV is a horizontal view of the penetration plane, and OPV, so this is a vertical view of the penetration plane. So from the PPV, we can see the wire chip always straight. But from the OPV, we can know the direction of the guide wire chip and the distance from the guide wire chip to the target. So of course, to complete this strategy, real perpendicular view measurement is very important. So that we calculated these two perpendicular views by the vector projections method. So from the randomized two projections, the coronary angiograms, so behind the coronary angiograms, so actually the coronary artery is a three-dimensional structure, so that we can reconstruct the vessel vectors from the randomized two projections of the coronary angiogram. So again, we check the coronary angiogram, the two direction, and finally we can calculate the vessel vector like this. So already as a Hintech, they developed the software to calculate the perpendicular view. So in this software, we can angiographic data from the DICOM viewer. So this software included the DICOM viewer like this. So we selected the one angle, the vessel vector. This is the vessel, but this time we calculated the vessel vector around here. So anyway, we stopped the image and put the image to the software like this. And also we can select the other view. So from the RO view, we selected the one images and put the image to the software. And then, so after making the line, so where do we want to know the Bessel vector like this? So after that, is the software calculated the orbit like this. So Bessel vector is a white arrow like this. So that around the white arrow, so we can select it randomly is two perpendicular view like this. So we can know the we can see the orbit like this. So for this patient, is RL44 cranial 11 and LL44 the cordial 10 is a real perpendicular view for this Bessel vectors. So and also we to complete the penetration plane method is the movement of the cardiac is a very one of the limitations. So now we are developing the ECG synchronized fluoroscopy. So image we can get the one timing during between the RR interval. So mainly the endodiagnosis is one of the best timing of we can get the images. So after synchronization, you can see almost stopping coronary artery like this. So I showed the one cases. This is the one light coronary CTO, not so long one. So you can see the breaching collateral from the artery branch. You can see some distal landing zone like this. So this is images. So CTO length is around 15 or 20 millimeters is here. So anyway, at first we should penetrate the proximal cap of the CTO with the IBUS guiding. So this is a conventional procedure. So we checked the IBUS, the wire is inside in the true lumen. And advance the guide wire with the usual practice. So anyway, the guide wire is almost located the distal landing zone like this. So now we can use the penetration plane method to the entry of this wire to the distal landing zone. So to complete the penetration plane method, now we are developing the navigation software. So if we can draw the distal landing zone in the angiogram, so this meaning we can always see the distal landing zone. This is not the CTO procedure. We can see the target always. So this is very helpful for the operators. So after calculation of the distal landing zone, and so we can make it the mapping is like this. White line is the distal landing zone of the Bessel vector, and the yellow line is the end of the distal target. So that this means the distal around here is the distal cap of the CTO. So this is OPV, so that we can check the direction of the guide wire. So guide wire is almost close, similar, close to the distal target. And this is a penetration plane view, so that we should control the guide wire. We should control the guide wire to the straight line, so like this. So in the PPV, PPV, you can see the guide wire, the chip is almost straight like this. And also the chip of the guide wire is almost asleep to the distal landing zone. And also we should check the direction of the distal chip of the guide wire direction. And finally, we can check the angiogram without synchronization, so we can confirm that the wire position is in a true lumen like this. So in this procedure, we use the conventional mechanical guide wire GuideNexpo, but basically this methodology is developed for the plasma-mediated ablation system. So to complete the penetration plane method, so mechanical wire is some hard mechanical wire quite works well in this hard region, but everybody knows is some, even though the hard wire is slipped around the distal cap of the CTO. So, but the plasma wire can get the can make it a crack around the distal cap of the CDO. So it has a different power of the compared with the mechanical power. So we can, with the advent of the new devices such as the plasma-mediated ablation system in the near future, so new guide wire manipulation method, penetration plane method, and the ECG synchronized system have emerged. Thank you for your attention.
Thank you. So the last two topics will be introduced by Otsuji.
Yeah, I'd like to invite the next speaker, Byeong-Keuk Kim from Severance Hospital, please.
Thank you, Chairman. So today I would like to talk about the intracoronary imaging for the successful CTO PCI. This is my disclosure. So how to use the intracoronary imaging for CTO? So the first one is pre-procedure, and second one is during procedure. So this is our randomized CT-CTO trials. From the CTO, this trial is a CT-guided pre-procedure, CT-guided CTO PCI, very related with a higher success rate as compared to the just conventional angiography guided PCI, especially in the region of the difficult CTO is more beneficial as compared to the simple CTO. So this is the some form of the CT analysis of our CT-CTO trials. We firstly make the two orthogonal CT imaging matching with the CAG, and then the qualitative, quantitative analysis, including the segment analysis. So in case of the blunt stump or long tortuous CTO, is a CT show the exact anatomical location related with the adjacent side branch and the course from the proximal to distal CTO cap. This is the analysis of reason for recanalization failure in the CT-CTO trials. As you can see, the failure rate to enter the cap due to the anatomical ambiguity is there was a statistically significant difference is higher in the angio-guided group. So this is the aorta ostial CTO case is an invisible coronary artery ostium from the CAG. So the we did not know from the angiography exact location of LAD ostium. However, CT revealed some hidden course of the separate LAD ostial total occlusion region. So the very easily perform the procedure with the wire successfully wiring, and then this is the final CAG. So the next one is the CTO with the severe calcification. CT could visualize the CTO course and plaque characteristics. So and also in case of reattempted CTO cases, is a longitudinal and cross-sectional result is very related with some decision of the planning of the CTO. So this is the some very different kind of failure reasons is exactly lower in the CT-guided group. So, and also is antegrade only crossing time is very short, and also even with the marginal statistical significance, however, the rate of the coronary population or a large peri-procedural MI had intent to have a lower instance in CT-guided group. So this is some case of the retried CTOs. Considering the previous failed of the CTO pass and then the basing matching with the CT scan, we could draw for the new puncture line. This is the previous site, and also based on the some MPL image and cross-sectional image, we decide new puncture point in case of the blunt stump. So and also this is the some kind of application of the PPM using the pre-procedure CT scan. Is as a previous Nasu already showed us the importance of this method. So it's very similarly we can decide the proper angiographic matching angle based on the CT findings. So what about the image-guided CTO PCI during the CTO procedure? So this successful CTO case is LAD CTO, circum CTO, RC CTO, and circumflex CTO. These all cases finished the CTO with successfully. However, these are all cases with the cardiac deaths during our previous CTO IVUS trial. So when you compare the clinical outcome of the IVUS guided group and angio guided group, so the MACE is definitely low in the IVUS guided group. Cardiac death or MI is significantly higher in the angiography guided group. When you look at the death or MI case, there was no case of the previous IVUS group. However, so all case is occurred in the angio guided group. So how to improve the clinical outcome, usually in complex reason? From our two clinical studies, CTO IVUS and X-ray IVUS, is definitely the final adjunctive, the frequency of the adjunctive balloon and pressure, and also the diameter of the final MSA is definitely greater in IVUS guided group. So if that the imaging guarantee the successful outcome from our study is definitely different. Patients meeting the criteria show the improved clinical outcome. So it means the IVUS guided obtaining stent optimization would be the key for the better outcome. So this is the some patient level analysis of our previous study. So we invested of the IVUS criteria for the CTO. So from the merged data is definitely patient with the stent optimization group showed a significantly low rate of MACE. What about the criteria in CTO is very similar, is MSA greater than the 4.2 or percent expansion greater than the 75. Based on these values, even with the number was not so high, but the statistical significance was noted. So the angiographic outcome of stent optimization by IVUS guidance. So we frequently observe the distal vessel expansion after successful CTO intervention. From the CTO IVUS trial, is a patient with the stent optimization showed a little bit higher rate of the distal vessel expansion, meaning the stent optimization is a slightly improved distal vessel expansion after successful CTO intervention. So what about the way to obtain a better optimization and expansion during the CTO PCI? The same patient group, this is the comparison of the reason with the pre-stenting IVUS versus the reason with the pre-stenting IVUS negative group. So when you compare these two, is MLD and also MSA is a little bit greater in the pre-stenting positive group. So in the CTO subset, especially the pre-stenting IVUS positive, meaning the pre-stenting IVUS evaluation was done group is compared to the negative group showed a better composite outcome with a great statistical interaction was noted. In case of a CTO PCI, the determination stent size and length is difficult due to the long-term reduced flow. However, pre-stenting IVUS evaluation in CTO would be helpful for the better angiographic and clinical outcome. So, and this is the recent data of the Renovate Complete PCI trial by the Professor Han. In this subgroup analysis, CTO subset is also definitely a significant higher improved clinical outcome by using the imaging guidance. Ladies and gentlemen, this is my conclusion. Is a pre-procedural imaging by coronary CT scan would be the helpful and significantly associated with the higher CTO success with the lower trend of complications like coronary perforation or large PPMI, and also related with the high efficiency, less time in the antegrade CTO in difficult CTO. And intraprocedural imaging guidance by IVUS is significantly related with a better clinical outcome, short-term and long-term. However, because IVUS guidance did not guarantee the improved outcomes, the attainment of stent optimization would be essential, especially in the complex reasons, including CTO. Thank you for your attention.
Thank you very much, Speaker Kim, for the nice lectures. So I'd like to invite the last speaker, Dr. Chiung-Jen Wu, co-chair today from the Kaohsiung Changung Memorial Hospital, Taiwan. Dr. Wu, please.
Okay, thank you. So this is my disclosure. This is one of the example wire pass, but any device cannot go for the antegrades. This is a CTO in the already proximal, also diffuse disease in the circumflex and RCA. The operator fixed the circumflex, but however, the already CTO, he luckily able to pass by XTA wire, but he using a guide extension to support any device. However, finally, spending 5 hours cannot success. So if you have started with a guide extension or guide caster, for example, 6, you can improve your support by increasing to larger guiding, or maybe guide extension, deep-seated, a passive type of guide extension, or maybe body well, or the balloon anchoring. So easily to remember, this is a anchor, body wire, changing guiding caster, deep-seated, engagement, A, B, C, D, E, F. This is another one is device cannot pass. You can use a balloon assisted micro dissection. We have another saying is green needle process. This is one of example. Chip CTO, already not a long CTO, but balloon cannot pass. So the anchor balloon, 7 French guide using IBB support. This is 1.0 balloon intentionally to rupture the balloon, and the second balloon able to pass, and the dilatation facilitates a microcatheter to exchange the rotor wire. And this is a rotational hysterectomy with 1.5, then final angio like this one. Actually, the LVF is improving after this procedure. Another case is anomalous RCA from the left cusp, but this is operator using a guide extension and externalization already, but using a turnpike go, unable to pass the CTO like here. So we have to shooting with a rotational hysterectomy wire and perform the 1.5 millimeter burr. This is, and after that we are able to deliver the stent, but stent is not expanded very well. So this is a 3.5. We go to 24 atmosphere to achieve a final good result. The same case, the first case, he referred to me, we go with a retrograde approach. XTA able to pass from retrograde into the ascending aorta. I was confirmed the position in the true lumen guide extension to capture the retrograde wire, balloon trapping in the guide extension. However, still cannot go. We facilitate retrograde microcatheter, even change fine close, 1.7 instant pass from APT, China-made microcatheter Corsair, extra small. Then we use a retrograde balloon passing, try to breaking the CTO using 3 smallest balloon, but still cannot anchoring balloon the pure branch. So this patient actually will create some complication. So this is one of example for this case. Wire extension, how to solution for this kind of situation. Wire extension, this is one of my proposed extension to the XTA wire, gradually pushing out of the antegrades EBU4. Another microcatheter short from antegrade roots, rendezvous near the CTO exit, then removal of retrograde wire and try shooting with rotor wire. This is one of my proposed. And then do a rotational hysterectomy, or maybe if you can do without changing laser, if available, maybe still can use. Secondly, microcatheter CTO distal exits from the retrograde roots, remove the XTA wire. We try shooting with RG3 wire, and hopefully we can pass through, then into ascending aorta, then snare out, then from the antegrade to do a balloon assist microdissection, tonus, turnpike go, laser, or shooting with a rotational hysterectomy again. The third proposed is to bypass the hard rock. For example, we intentionally bypass the hard rock with puncture to the subintimal, then create a subintimal connection with a reverse cut. This is RDR. Of course, we can do ADR. The fourth proposed, this is Nasu. Actually, we actually perform one the very challenging end-stage renal disease using electrical coagulation power to penetrate that RCA osteo CTO. This is one of example of one that I did an invitation to the CTO, but that hospital, they don't have rotational hysterectomy, so wire pass, any device cannot pass. So we intentionally go retrograde, and after retrograde, we intentionally do knuckle here, like this one. We bypass the hard rock and the wire pick up in the guide extension. Then we do a stenting in the subintimal space. So this is a final angio, like this one. Another case, this is a failure 2 times, antegrade puncture, even with the hardest wire start of 40. So I was invited to do a retrograde, but at this position, we intentionally to bypass that the hard rock here in the mid LAD, and after that we can puncture the root of the knuckle wire and penetration, and then do a double knuckle, and we use that very hot. You need a corseal to penetrate this antegrade penetration. Then we do a reverse cut, final angio like this one. Of course, we have some subintimal because antegrade knuckle, so create some intramural hematoma. We have to do a cutting balloon to release. So this is one of the example, end-stage renal disease, anterior, and the CTO plasma cap is very hot. So while actually can penetrate to here, but any device cannot go. So for preparation of the antegrade reverse wire, so reverse cut, so we have to use rotational treatment, just breaking that plasma cap. After plasma cap breaking, we have to go for here, and also, of course, we started the retrograde approach, and very tortuous RCA and very calcified, so we have to do a double knuckle and the final reverse cut while can get into the ascending aorta. And this is a snail pickup and reverse cut again, and this is a microcase that can facilitate get into the guiding, and this is a final result of this end-stage renal disease. So sometimes while passing through the CTO calcified portion is antegrade retrograde, but smallest balloon unable to pass, try grenadoplasty, BAM, or turnpike go, tonus ADA or rotational hysterectomy. Laser can be done without changing 014 wire, but hard rock may not work also, not routinely available in all the cath lab. Rotational hysterectomy needs wire exchange through the 014 wire created channel. It can be done in more than 90% in our cases. IVL orbital need to create a small channel before passing, cutting, score fix, NSA alpha, OPN also similar. So in considering of this, bypass the hard rock would be other alternative, but drawback of subintimal DS stenting, they have a 2 paper regarding this. ISA, OCT, CTO registry, can see that malposition and uncovered strut was somewhat higher in the subintimal stenting, and also procedure-related MI was somewhat higher from the coronary university. Thank you for your attention.
Thank you very much, Dr. Wu. Now, these 5 topics will be open for discussion. First, from the panel, any question or comment? Yeah, Dr. Seon.
Dr. Nasu, thank you for your nice lecture. You always show us a novel and fabulous technique for the CTO PCI. So penetration plane method must be one of the therapeutic methods for the CTO PCI. However, it can be available. It is available only Canon device, and the other is the vector calculation do in the ECG gating system. So in the patient, if patient have cardiac arrhythmia such as atrial fibrillation or VPC, so some difficult. So how can we overcome this method? I think the new how about adding a new method such as rotation slab MIP imaging? Dr. Hasegawa presented. What do you think about it?
Yes. Anyway, actually for synchronized ECG synchronized angiogram, regular heartbeat is needed. So the we cannot use ECG synchronization, the patient with atrial fibrillation or some patient with arrhythmia. But the most important things is we can evaluate the CTO segment or distal rounding zone from the real perpendicular views. So our software is the first step is the calculation of the two angles. The real perpendicular views is very important. So even though, of course, we can get the perpendicular views from sometimes we can get these views from the CT findings. It's very useful in the clinical setting. Is okay?
So that software that you've been developing, or I think Dr. Yamani's been involved, is that compatible with just the Canon system, or is it more widely compatible with Philips and Siemens and other systems?
Yeah, okay. Actually, Philips has also the ECG gated system, but not synchronized. So, of course, we can get the two perpendicular views without synchronized angiogram, but to get the stopping coronary artery images, we need so far we need the Canon system.
I have also a question to Dr. Nasu. Yeah, conventional CTO wire can control only shaping and push and pull, and rotation that's all. But usually power transmission is limited after torches are passed through the torches vessel, and then we cannot fully control the direction, I mean a vector of vessel, and we cannot fully control the penetration point by conventional CTO wire. This is our real situation. So do you think, is there any ideal method, like I think of plasma wire, possibly control, and another option is nowadays magnetic control wire can fully control direction of a wire. But
actually, the magnetic wire control, I have no experience, I cannot answer. But even though the plasma wire, this is a mechanical guide wire. So as you mentioned, in the tortuous vessel is a torque transmission is very less. And also, if the very big space around the tip of the guide wire, so guide wire control is very difficult, everybody knows. So, but if the advantage point of the plasma wire system, so if the tip of the guide wire touches the target, so and we can make it abrade, so we can make it a crack. So that's meaning that we can, you have some chance to insert the guide wire chip inside the atherosclerotic or some distal cap or something. So this is a different point. But basically, even though the plasma wire, this is a mechanical guide wire.
Dr. Wu, very, very happy to see your complex procedure, similar to me. Okay, my question and comment is, in case of before the bilateral knocking or ipsilateral knuckling, so a few cases I experienced because of the calcium lock and very hard tissue, because we cannot control. So it accidentally went to small side branch and make a perforation, and another route dissection, huge dissection, and later on extravasation. So I preferably to do the CTO parallel wiring, already wire in, but any device cannot cross. So I'm calling that the calcium neglect strategy. So I always try to do before knuckling, intraluminal using stiffer tip, bypassing the calcium lock by the intraluminal wiring fashion. So antegradely or the retrogradely, and usually retrograde more soft. So in that case, I never failed to cross any device. So to prevent the complication for the younger intervention, I prefer to comment on the intraluminal bypass, calcium bypass strategy preferred, and then fail, then maybe finally we can do the, any wire-based CAR-T, reverse CAR-T bypassing this calcium rock. How about your opinion?
I agree, totally agree, because because in Japan, in Taiwan, we have a lot of uremic patients, so that is difficult. So even as subintimal, you can face very hard. You cannot even breaking that part. So that's our weak point. So if that for example, you have a calcium, but you still, beyond the calcium, you still have a space you can penetrate. Of course, that is good. So you can do as you wish, the parallel wiring. So I'd like to have Otsuji's comment regarding this, or maybe Scott regarding how to bypass the hard rock. I don't know. This is
we always try to advance wire in the interluminal, not subintimal.
Yes.
So, but the very rare case is very difficult to enter the interluminal in such a calcium and tortuous vessel. It's I think that knuckle wire, bilateral knuckle wire is the last option. If in the case we cannot pass the interluminal plug.
In my case, I have one more option, because already CT wire is in, so using another stiffer CT wires, I'm doing the parallel.
We tried always,
Yes.
but sometimes fails.
I just make one.
Making more intraluminal space by the multiple parallel wiring inside.
I'll make one comment. I agree completely that staying luminal is better than subintimal. However, it depends on whether there is ambiguity of the course or not. And this is the problem, right? We now have these very stiff wires, Gaia 4 Next, Sharp Tip Conquest Pro. They're very good if you know where you're going. If you do not know where you're going, or there's ambiguity, they are very dangerous.
Yes.
Particularly for non-expert operators. So my comment is that sometimes knuckling is good, particularly when there's ambiguity, which makes use of very stiff wires very dangerous.
Of course, limited knuckle length is very important.
Yeah, I have one question to Dr. Wu. So knuckle wire is also very useful for such a situation to avoid the calcified plug. But also sometimes so knuckle wires make a very big perforation with side branch or something. So which wire do you recommend to use knuckle wire?
As I have a good gradius, but usually I only use the Gaia series, or maybe the previous, we don't have a gradius, but right now we have a gradius. Maybe I'm still learning how to use that properly, but to make it smaller loop, not the big loop. So what about you, Scott?
Look, I think, people think that knuckling wire is easy. You just push. It can be very dangerous, right? Uncontrolled knuckle, particularly if it goes into a side branch, it is a potentially dangerous thing. So certainly the Gladius MG makes a much smaller knuckle because it's designed to do that. It doesn't knuckle at the transition, knuckles much earlier. And that's a good thing because it limits trauma to the vessel, but it's a bad thing in that it is more likely to knuckle into side branches. Because when you have a big loop, you tend to avoid the side branches. So I like the Gladius MG, but the thing you have to be careful about, because it makes a small knuckle, it might knuckle into a side branch. And so if it's deviating off course, then you need to have that aware.
Okay. So you think big knuckle is better than the small knuckle?
No.
Depending on the case, I think.
But I think the awareness that a knuckle will not always go in the right direction, and understanding the limitations of the knuckle is important. And sometimes you need to redirect with a wire over a short segment. But I agree, intraluminal is much better, but ambiguity is the enemy, right, with stiff wires.
Okay, thank you very much. It's time to close this session. Thank you.